on the live stream as well. I'm just going to introduce our time briefly, then Greg is going to do a presentation, then we'll have Q&A afterwards, and our doctors, our resident doctors, will answer every possible question definitively with reference to COVID. I'm just joking. Now, from the start, the leadership of River Oaks sought to make decisions in response to this COVID crisis with biblical wisdom. And in this situation, we've sought to apply three principles, essentially, the two great commandments, to love God and to love our neighbor, along with the third principle of our duty of being honorable citizens, submissive to human governments that God has established. So love of God, of course, focuses on our duty to honor him in all things by the way that we live, but not least of which our responsibility to gather for corporate worship. I mean, what it means to be the church is to be a people gathered. Love of neighbor focuses on the preservation of human life and our responsibility to defer our own preferences and prefer the preferences of others over our own. And then submission to government obviously focuses on our responsibility to be good citizens and stewards of our community. It's not easy to balance those three things. We've sought the wisdom of other churches and of many counselors, and we founded a COVID action committee to prayerfully think through all the developments as they really changed day to day. And under Greg's great leadership, I just want to publicly thank Greg for really taking on this task. In addition to everything else that he does, he's been instrumental in orchestrating this. And not only that, but just about every church that we talk to asks Greg, can you send me that? Can you send me that? Can you send me that? Because Greg has been blessing all of the churches in our area, in our presbytery as well. Also want to thank the COVID committee for their additional work and concern in partnering with us. The Bible says with many counselors, our plans are successful. None of us has all the wisdom on this, and so we were thankful for that committee. I want to especially thank Dr. Bagoulias, Mike Bagoulias, who's been really in constant conversation with Greg and giving us advice and insight into what's happening in the ground. And so thank you so much. It's been really I can't tell you how much of a contribution it's been and a comfort to Greg and I just to have someone that we trust to be able to filter all that we've been hearing. So
and Kim as well.
And Kim as well. Yeah.
She gives me all the data I need.
All right. Doctors Bagoulii have been fantastic. Though Mike is my favorite. Anyway. I'm just kidding. I just talked about favoritism. So without further ado, I will hand it over to Greg and let the presentation go on.
It's been forever since I've stood right here and done a Sunday school-like thing. So it's good to be with you all. Good to see you. We've got a lot of folks there at home as well. And if you want to go and review everything, this afternoon we'll have the presentation and this video available. I'm about to go through a whole bunch of slides, not all of which I can spend a whole bunch of time on. But so I'm going to go somewhat fast intentionally so that we can get to the Q&A. But if you want to go look up these numbers and so forth, all of it is footnoted and you'll see the presentation on the website, hopefully this afternoon. Bit of a roadmap of where we have been. February, March is when this all went down, as you all know. We've gone through, as David mentioned, a long process to get to where we are today. We started our reopening in May under stage 1, and I think we had 14 people here the first time around. We're in now stage 2, which we began in June. And I know probably all of you are feeling it because I'm feeling it too. Something has changed culturally over the past week or two, where I think, especially with school starting and UCF coming back, it feels like the brakes are now being let off. And folks are, by and large, for better or worse, we're getting back to life more and more, regardless of the headlines. And so we are trying to sort of anticipate, okay, what is that going to look like for us? That's the reason why we're having this meeting. In light of the fact that, by and large, certainly in Florida, we're just going in there. We're just getting after it. What does that mean for our church life? And so that's the goal of today's meeting. David's already covered our guiding principles. And so I have 3 things that we want to cover today, some of which may be slightly controversial. Not everyone is going to agree with everything we're doing. Some are going to be on the more, let's just get back to life side of things. Others are going to be, no, maybe we need to continue sheltering and being cautious. And so one of the biggest challenges we faced is, how do you deal with that as a church where we have everybody on all the parts of the spectrum? And so here's where we're heading, and we just ask for everyone's patience and understanding as you have been since March. Our first principle, and I'll try to sort of show you this from the data, is that right now it seems like COVID-19 and coronavirus is here to stay. Even just now, I was looking at it before this presentation. There's a new Fed Reserve guy who's saying we need to shut down for 6 weeks, nobody go anywhere, and we'll nip this in the bud. So there's still those calls, and certainly different states are at different points on this, but it seems like at this point, COVID's here to stay. Florida, as you all know, we've been all over the news for the past 2 months. We've been in a major spike. Most likely we're going to plateau or maybe see these spikes. It's in essence, we're going to have to learn to live with this. And so I want to try to articulate why we are persuaded that that's the case, that we're not going to wish this back to zero. And if it's not going to go back to zero, what do we do? That's the question. So point number 2, and I have a bunch of data on this, we're persuaded that the risk factors are far better understood now than they were in March. And therefore, we don't need to behave like we did in March. We can behave now based on better data and ignore the headlines, but actually follow the data where they lead us. And so that's been a big input into our decision-making process. And then finally, what does it look like to re-energize Rock in the fall? We've had 60 people coming to Sunday services. That's by and large what we've been doing. Youth have been doing some things online. Children's ministry has been put on pause by and large. Community groups don't meet during the summer anyway. So what does it look like to head into the fall, living life in light of COVID, and re-energizing, re-engaging, and so forth? What does that look like? And so we'll conclude the presentation with our plan for the fall, tentatively speaking, and so forth. So point number 1, COVID-19 is here to stay. And I'm going to go through this, as I mentioned, as fast as I can, and then we'll do the Q&A. So I'm not going to pause for questions now. We're persuaded that COVID-19 is here to stay. You've all seen these kind of charts. This is accurate as of yesterday in terms of cases. There in the red at the very bottom, and then the positivity rates in the green line there. We've been hovering at 20% for the past month or so. It started to trend down, as you've probably seen this week. On top of that, so as of yesterday or Friday, there are 510,000 diagnosed cases in Florida, total population of 21.5 billion. So we're looking at something like a 2.4% identified infection rate. People who have actually been tested. And of course, there's all kinds of noise in the numbers. We all know that, but by and large, is what we have. And so that's the number. However, in July, there was a very important study put out in JAMA, the Journal of the American Medical Association, that estimated that for Florida at least, and they did several different states, but for Florida, they found based on serology testing, which also has a high margin of error, but something like 10 times as many people in Florida have had COVID, but not been tested. So you do the math, that means something like the actual infection rate is more like the 20%-ish. And that checks out roughly when you look at the national statistics. Most studies on this so far are assuming and saying that at least 5 times as many people have had COVID than have tested, maybe up to 10. Again, it depends on who you ask. Now, there's a lot of debate about whether that is close to herd immunity or not. No one really knows yet, but if 1/5 of the population in Florida has or has had COVID, it's probably not going away at this point. Bunkering down isn't going to make it go to zero. Masks apparently help, and most of the recent studies have shown that they do help in various ways, but by themselves, they're not going to sort of magically be some pixie dust that's going to make COVID just go to zero. Staying at home in perpetuity hasn't worked really anywhere. It's not a viable strategy for most people, and it's not healthy for our spiritual lives. And everyone's sort of pinning their hope on a vaccine. May or may not happen. Maybe it's 2021. Who knows who's going to take it? I'm probably not going to sign up to be the first one to get the vaccine. And so the reality is it's here to stay, is our current position. And the question is, what do we do about it? As opposed to, should we just continue not doing anything and hope that it sort of goes to zero? So that's point number 1. COVID is most likely here to stay. Point 2, and we'll spend a bit of time on this. The good news is, if there is good news, I suppose, is that we understand the risk factors far better than we did when we shut things down in March. Something I talked about with Mike, the lesser Begoulius. I had to make up for that. Is somehow in March we went from saying let's flatten the curve, let's protect everyone, let's protect healthcare professionals, but this is going to burn its way through because that's what pandemics do. We went from that perspective in March to, for some reason, no one should ever die ever again, and we need to do everything we can do to save every single person. And I resonate with that. No one wants people to die, and the death toll is staggering. But as Christians, we have a different perspective on this. Death is our only thing we should ever be worried about, and no one should ever die ever again. The Bible is clear that death is not something to sort of constantly be neurotically obsessed about, but something that we just deal with. And it is something that is going to happen to all of us should the Lord tarry. And so it's better to think in terms of, okay, how do I live in light of the shadow of death, as opposed to what can we do socially to make sure nobody ever dies of this ever again? Because as you all know, it's sort of like, well, we still drive and we still eat fatty foods and all these other things that kill us. So that's one thing. The COVID death toll, and I'm not trying to minimize the death toll. It is startling. It is sad. It's been very bad in the U.S. relative to some other countries. But it's also important to realize the broader context. Roughly, and you know, when you see, okay, another 200 people died today in Florida, and that's sad, and we grieve with people whose loved ones have died. Obviously, we do that, but it's all worth keeping in mind that roughly 4,500 people die per week in Florida. We have one of the highest weekly death tolls in the country. And thus far, at least up until the past 2 weeks or so, the number of non-COVID pneumonia deaths, as an example, are higher than COVID deaths. It started to sort of switch now because, generally speaking, pneumonia season, goes down in the summer, so COVID deaths are now higher. But up until recently, pneumonia deaths, these are people who didn't test positive for COVID, have been higher. Generally speaking, about 1,000 people die per week in Florida of cardiovascular diseases of various sorts. And so I'm not minimizing the gravity of COVID, but showing that basically this is going to be, even with a vaccine, something that's added to the very long list of things that can possibly kill us. And so again, the question is, okay, now what do we do in light of that reality? And here's just the data behind that. You see the blue line there is total deaths in Florida per week. So it hovers right around 4,500. And then you see at the very, very bottom, the red line is the COVID one. And so it is bad. And it's obviously trended up recently, but it's, it almost barely registers on the sort of total ways we can die in Florida. Here's probably the most important chart, and something that hasn't gotten a lot of publicity. This is my own cutting of the numbers because you can't really find this stuff very easily. And this is probably the key insight that should shape what we do going forward. This is based on Florida. The blue bars are cumulative deaths. Of course, deaths keep going up, and death has a almost perfect track record. The orange bars are cumulative hospitalized. And so that's what everyone's like, oh, freaking out. Okay, that's bad. And it is bad. Lots of people being hospitalized, something like 22,000 year to date for COVID, and 7,000 as of Friday have died. But the lines, the green line and the red line, are the percent of people who test positive who end up in the hospital or who end up dying from it. Again, this is for Florida, so you take out New York, New Jersey, and so forth. And it has trended down in a substantial way since the beginning of the pandemic. Hospitalization rate has gone from something like over 25%, that's when everyone was freaking out, right? And we were going to be the next Italy, to less than 2.5% as of this past week. And the death rate has gone from something like 7%, which of course that was terrible, right? That's a huge death rate, to something closer to 1% in the aggregate. And so that shows A, that we're getting better at treating it and identifying it, and B, for whatever reason, it's just getting better in terms of how we have our sort of act together in dealing with it. But probably the most important one, this is going to be hard for you to see, but again, you'll see the data online after this presentation. It's very, very, very important to stratify all of these numbers by age. And when you do that, some very important things show up. And basically, you could do this chart for every age group. If you go back one slide. This downward slope of hospitalization rate and death rates, you could do that for every age group. And so instead of having a bunch of different charts here, I just have a data table. If you break it out, and again, this is something you have to go and dig through of 500,000 rows of data to do because no one's publishing this, so this is my own cut of the numbers. If you stratify by age bracket, 0 to 14 years, 15 to 24, 25 to 44, that's my bracket, 45 to 64, that's David's bracket, it gets worse, 65 to 74, and then 75 plus. You can see total cases there in the first column. I don't think this shows up on the screen. Total cases, so there's your 500,000. This is as of the end of last week, because this prior week's data isn't finalized yet. Total number of hospitalizations, total number of deaths. But when you break it out by age, some very important trends emerge. Look at the 0 to 14-year-old bracket. Yes, there are 283 hospitalizations and 3 very publicized deaths, and that's sad and that's terrible. But notice the hospitalization rate has gone from 6% in March to 0.7% in July. Again, because we've gotten better at identifying and treating it. The death rate has been 0.01% really all along. 3 people divided by 26,383. You look at the next age group. So this is going to be sort of our youth population and young adults. Hospitalization rate has gone from 4% down to 0.5%, and the death rate, again, barely registers. There's only been 18 deaths out of 73,000 identified total cases. Again, not minimizing those 18 deaths. We grieve those 18 deaths, but when you quantify it, it's 0.02% chance of death in Florida in that age bracket. It starts to go up a little bit as your age brackets increase, but the most important number probably, if you look at the 75 and over line, and as Christians, we highly appreciate the 75 and over crowd. The rest of society doesn't always do that. But if you look at that population, they make up 4,500 of the 7,000 deaths. The hospitalization rate in March was 34%. So 1 out of every 3 in that age bracket who got COVID ended up in hospital, and 10% of them, over 10% of them died. 30% of them died. But it has come down to 11% lately on the hospitalization side and 5.3% on the death rate side. And so you can't just sort of smash them all together in one big pool. You have to stratify them from an age perspective and say, okay, who's really the highest risk population here? And statistically, it really is the 75 and over crowd, and then sort of a slightly heightened risk for the 65 to 70-year-old crowd. But everyone below that is basically within the ballpark of a hospitalization and death rate that you might see for getting in a car accident and that kind of thing. Again, it's bad. Death is bad, but we have to sort of look at the data in an appropriate and accurate way. Think of the biggest bulk of our church will be in the 45 to 64-year-old range, and the current death rate as of July is 0.24% of those who actually contract and test positive for COVID. So stratifying it by age is a big deal. It's also important to keep in mind underlying conditions. And so this is from the hospital system in terms of the percentage of hospitalized patients who have a comorbidity or an underlying condition, or more than one of them. And this is the list. You all probably have seen this. You probably just haven't seen the statistics, but over 50% of people who are hospitalized have hypertension, roughly half have obesity, and often multiple ones, and so on. So it's important to keep in mind that that's the subset of this age, of each age group that presents the highest risk. And so we have to sort of factor in all of these different complex aspects of the data to be able to make any sort of decision. Now, if you narrow in from Florida, and it's important to bracket out Miami-Dade and Broward and so forth, because they really drive up the numbers. If you look at Seminole County, we've been pretty much holding steady. It's mostly the younger population who have tested positive. 450 some odd hospitalizations. You see our daily cases there as that bottom graph have started to flatten out and trend down, and our percent positivity rate has gone from something like 15, it's back down below 10 as of Friday as well. So we seem to be sort of holding steady here in Seminole County. And again, it's important to look locally and not just sort of throw a bunch of other hotspots into the mix. Now, one of the things that's been sort of a constant thread in the media of us selling of this in Florida is that we're running out of beds. And it's all going to go back because we're not run out of beds. But I have it on good information that we're not going to run out of beds, that the major hospitals, and it's not just people who have told me this, but if you look at all the press conferences involving hospital administrators who are actually saying this, is that they're fine. They've been fine the whole time. They have plenty of PPE, they have plenty of beds. Whenever they say, okay, we're at 90% utilization of our ICU beds, well, keep in mind, they normally run at 90%, and they don't keep all their ICU wards open because it's extremely expensive to staff them. And so if you have 5 ICU wards and you only need 2 of them, you don't just randomly staff the other 3 and keep people staffed and keep the lights on, so to speak. You use them when you need them. And so if they need to start using an additional ICU ward, then that makes the denominator go up. Therefore, the percentage utilization goes down. All the major systems in Central Florida report they're sort of green for everything in terms of they have the right medications, they have the right staff, and so forth, and they've received extra staff where needed. Here's the biggest question that we've been grappling with: what do we do? What do we think about children and youth? And for those who are parents, we've been neurotically obsessing about the school decision and what to do with our children for the past 2 months. I know I've been in that boat. Here's the best we know on the children and youth side of things. First, it appears that the testing positivity rate is higher for children And so percentage-wise, more are testing positive than your average adult. But that's most likely because children aren't generally tested unless they show symptoms. Whereas a lot of adults, like myself, I got tested because we're going to go visit family. I didn't get my kids tested, but I got tested. Tested negative. But a lot of adults test regardless, or like the NBA players or whatever. And so children generally are only tested when they show symptoms. Therefore, it makes sense that their positivity rate would be higher. So there's nothing really to worry about. Children are, on the whole, less susceptible to being infected if they are exposed. And so this is called the attack rate. So if you have a known person who's in the room and someone is positive and they don't have a mask on or whatever, and they're talking, and if you have a bunch of adults and a bunch of kids that are around that person, that's an exposure for if they're there for a particular amount of time. The studies have shown that roughly 6% of those kids contract the virus versus something like 50 to 60% of adults who tend to apparently get it at a higher rate than children for whatever reason. Could be because children have higher immunity to corona type viruses and so forth. Third, the severity has been much less, and this is like the biggest sigh of relief for us all, is that for the pediatric age range, the severity has been much lower, as we've already seen, by the way, on that other chart, than the average individual. So 590 out of 100,000 people who are 85 years and older end up in hospital, but only 7 for the pediatric age group, and there's other numbers that we could throw at that as well. The biggest question that everyone's been grappling with, and if you have children in school age, this is top of mind, but it's also top of mind in the news, is what is their secondary transmission rate? How often do children spread it if they have it? Maybe they're running around, they're perfectly healthy, as most of them, in fact, 99.8% of them will be, but do they spread it to their teachers, to their parents, to grandma, and so forth? And the data is a bit mixed on this. The studies from overseas, Ireland, Australia, and other places, Israel, have almost been unanimous in saying that secondary transmission by children is very low. However, and you've probably seen this if you follow the local news, there's been lots of outbreaks at a Georgia summer camp where like 300 kids got it and the camp counselors all got it. We're starting to see transmission in the high schools, and a lot of the special education students in Florida have gone back to school, and so we've started to see some cases of transmission there. So it's a little bit hard to say what exactly that's going to look like. It's almost sadly kind of wait and see how this goes as the schools reopen. But in sum, the risk profile for kids for COVID is, and this is true, it is lower than for flu. Hospitalization rates and death rates for COVID for kids, in total deaths of 3, is far better than it has been for flu. Year to date, 14 kids in Florida have died of flu. None of them made the news. It's all very sad, but 14 from flu, and far more hospitalizations from flu than for children. Now, that's not the same equation for the older population. And that's where I think sort of nationally we missed the boat on this, saying this is just a bad flu. For kids, it is. For older adults, COVID is worse than flu, far worse than flu. So that's why you have to really stratify the information. The AAP, not the Florida version, but the national version, has been strongly in support of opening schools due to the low risk. The Florida chapter has been anti-opening schools, as Kim knows. Have they changed on that? Okay, I know like a month ago they were strongly against a reopening plan, whereas the National American Academy has been for it all along. So to sum it all up, and then we'll get to what we're going to do about it. COVID is real. It is easily spread. It's not a plandemic. It's not a fake thing. It's not a faux-demic. And it is very dangerous to certain parts of the population. None of that has changed. But what we do know now better than we knew several months ago is that the risk profile for children appears to be very, very low. It's not zero. Kids sometimes die from colds. Kids sometimes die from flu. As a 30-year-old, I could die from the flu. That's just a reality. But statistically speaking, based on the data, the risk profile, 39, I'm in the 30s, is very low. And healthy adults under 75, again, the risk is not zero. That's not our message today. Our risk isn't let's just party, right? It's not the message. But it is a better risk profile than we understood 5 months ago. Masking, social distancing, and outdoor venues do help us mitigate the risk. And so in light of all of this, here's what we're going to try to do to pursue something that feels more like normal while simultaneously protecting those that we can identify as the real high-risk groups. So here's our re-energizing plan, then we'll open it up for Q&A. All of this will be detailed in a blog post that'll go out this afternoon. First, we're going to continue with our in-person services under stage 2 for now. So we're still masking up. We're still trying to control for attendance to make sure that everyone feels comfortable with how far apart they are and so forth. I hope to resume adult ed soon. And today was kind of a test run of this to see how it goes. And in particular, how the entry and exit and the turnaround is going to work and spraying the seats. Thank you, Kathy, and so forth. And so when we do, I'm going to do a series on the use of the Old Testament and the New, so that'll be fun. Part B, we are going to start to phase in our children's and youth ministries after Labor Day. We're going to get a few more weeks to see what does happen on the ground. And if 20,000 kids end up in the hospital, Lord, hopefully not. But if that happens, then of course we'll change our plans. We're going to follow the numbers and see, okay, what is actually happening and so forth. We'd start with the nursery and keep it small with an RSVP, obviously. Then we would do, and this is all tentative, but we would start up with the rock, doing it outdoors at first. So that's when the kids leave during the service and do that outdoors. And then the youth meetings would also do the same. And then children's Sunday school, we'll phase back in when we feel like we can handle it, basically, when the data supports that. Third, and I'm most excited about this, we need to get back together again, more than just on Sunday mornings with our masks on and the sort of weird uptightness of like, what do we do? What are the rules? So we're going to have a series of Sunday night socials, 5 to 7 p.m. on the church lawn in the playground, kids included with social distancing. Bring a chair or a blanket. We'll spread out. The church will provide food. We don't have to wear masks because we're outside as long as you stay apart from each other. And we'll do that basically every 3 weeks through the fall, beginning on the 23rd of this month. And so this is 2 weeks out. David is going to do a vision presentation. Typically, what we would have done, what was on our version 1 of the plan, was to have a vision dinner on August 23rd. We're not going to do that, but this is going to be our replacement. And so he'll give a building update and a bunch of other vision-y kinds of things. We'll have dinner. The next one will be, I was thinking, well, it'll be maybe singing and music, but I was thinking, man, that's a bad idea. We'll see. So that one maybe we'll change and do something else. Tag or something. That'd be a bad idea as well. Like elbow tag. I was thinking singing is like the worst thing to do. So maybe that one will change. Then we'll do like top 10 YouTube videos that you've watched during the pandemic. And so we'll have like a way to submit that. We'll stream it. That'd be a funny way to laugh. It'll just be the Holderness family the whole time or something like that. If you know the Holderness family. And then in October, hopefully if we can touch stuff by then, do yard games, the can jam and that kind of stuff. So again, details pending, but that's one way to get us back together again. Community groups, we are sort of encouraging / allowing community groups to reconvene after Labor Day, which is when we would normally do that anyways. Some will do it in person. Like my group will start back in person. We may start out at a park, and then as we feel more comfortable with how it's going, maybe we move back to our living room. Right now, we don't want anybody in our living room, so it's not entirely true. But right now, we're like, what are the rules? But we'll start out outdoors. But other groups have said they're just going to do Zoom for a while. They have a high proportion of older people, and so they don't want anyone to be left out, so they'll start out in Zoom. And so it's going to be up to the group leaders to determine that, but we want community groups to get back going. Fifth, a new members class. All the new members from the spring were caught in limbo, to pull a term from our Catholic brothers. Do they think about limbo? I know they have purgatory anyways. And so we need to finish that up, but also we have some new folks that may be interested in joining. So we'll have an in-person and a Zoom option for new members, and then our men's and women's Bible studies would begin over Zoom, and then depending on their comfort level and so forth, consider potentially transitioning to in-person. So we're slowly getting our feet back in the pool is our goal. We're on this journey together. Our goal with all this isn't to sort of put pressure on anyone to sort of jump back in. It's going to be up to everyone to say, okay, I feel comfortable doing that. I don't feel comfortable doing that. We've got an email from someone saying, I'm not so sure I want to come back to community group yet. So that's fine. Don't have to. We are, as David mentioned, trying to make the best decisions for our particular church. And one of the things that's important to recognize is that there are still churches that we're very good friends with that haven't reopened at all. And that's fine. That's their decision. They haven't done anything yet in terms of regathering for anything corporate. They've been doing only live stream stuff. And others maybe are a bit farther down the path than we are. We're trying to make the right decision for us in light of our own constraints and in light of not just being a sort of political response to headlines. We're trying to sort of bracket all that stuff out and say, okay, what is right for us to do as a church to get back in the pool? Again, we're going to reassess constantly based on what's actually happening locally with the data, with the numbers, especially when it comes to children and youth. One thing I finally mentioned here, this is to do any of this requires a team effort. Sometimes I feel like I'm having to be like the bad guy, the bad cop. It's like, put your mask on or whatever. And so we all have pandemic fatigue. All of us are tired of this, and I don't like wearing the mask, and I'm tired of that. And I'm tired of, like, when I go to Aldi, it just stresses me out to the max, and I'm tired of that too. But these things that we're still holding the line on in terms of social distancing, masking, the reason why we do that isn't political at all. It never has been. The reason is so that we can keep the trains running. Lots of our sister churches have had to shut down and are still shut down, and maybe they're trying to get back up and running because they had a local outbreak and so forth. And we're not immune from that. But our goal is to do what we can to maximize who can be here to worship, and who can then go to their jobs and not have to quarantine for 14 days if someone shows up and spreads COVID. So let's continue. I'll just encourage you to continue being committed to self-sacrifice, even if it's uncomfortable, even if you don't like it, even if you disagree with it, actually. We're still asking you to be part of the team, to make these sacrifices for the benefit of other worshipers. So with that, let's open up to Q&A. So I'll invite Mike and Kim up, and we'll just sort of hover around up here. David's managing the chat. But I've hit you with a whole bunch of stuff and would invite any questions at this point. Yeah.
The first question I have is with the pre-K and the elementary school, will they be wearing masks outside, or we don't?
We're working through that now. As you may know, and I'd be curious to see what your take is on it from a pediatrician perspective. Schools are kind of all over the board in terms of masks, and I'm curious to see how that even goes, to be honest with you. We don't have a perspective on that yet. That's one of the things we're thinking through in terms of like in here, yes, for now. In the classrooms, we don't know yet. Kim, do you have anything to add?
Yeah, I think, is this on?
There you go.
Yeah, I think it's individualized right now. Some daycares, for example, that have those age ranges, they keep the kids together in cohorts so they don't have to make them wear masks. It's kind of hard for kids under the age of 8 to wear a mask and not constantly be touching it and kind of being against the purpose of wearing a mask. So I know some elementary schools are going to have like shields so the kids don't have to wear a mask when at their desks, but I don't know. So we haven't really thought about that. But
And one of our biggest challenges, of course, as you know, is space.
And so we're going to start like outside.
For rock, yes, we would start outside.
Will they have shaded areas?
Well, the playground is shaded. I mean, it's still gonna be hot, but for 20 minutes, it's basically a way to sort of get back to that rhythm. Nursery, of course, would still be inside, but we'll have to figure out exactly, okay, what are the numbers that we can handle? Part of our challenge on the children's ministry side is volunteers. Sorry, I'm not supposed to get too close to them. I'll go up here. Is volunteer manpower or man and woman power. A lot of the folks who have been part of our already stretched too thin children's ministry team haven't come back to corporate worship yet for various reasons, health concerns, that kind of thing. And so right now it's a bit of a skeleton. If we looked at the actual list of people who could be in nursery and do rock, it's a pretty short list at this point. So there's sort of a chicken and an egg. Some don't want to come back yet until there is nursery. Others, so there's a lot to figure out. Yeah, which is why we're partly waiting until after Labor Day.
Can you just repeat the question for the live
Yes.
stream?
The question was, will younger children in Sunday school, rock, et cetera, need to wear masks? That was the question. The answer is TBD. You have some other
What's the plan for the kids if it rains, like for the rock outside?
we would just stay inside. I mean, right now it's family integrated worship every Sunday, and so we would just continue doing that if it rained. Yeah. Other questions?
So, hanging on to the children's topic, so if I guess, do you have an idea of what the plan will look like for the rock session? Like, for right now, are they just gonna hang out on the playground? Or are we gonna set up a table or two to actually have some type of 10-minute lesson or something? Probably haven't thought through that as yet.
Yeah, so the question is, what would the plan be for outdoor rock? How would we actually implement that? And Joel and his team are still working out those details. They probably would be more than delighted to have input from someone who has thought about these questions. But my guess is initially, it's just good to actually have something, and then probably we would work towards, and we'll see how it goes. Everyone sort of dies of hydration, metaphorically speaking. I'll remove that in post. Then we had to reassess. So we're hoping that this will be doable for a 20-minute time period, but we'll see. Given that it will be hot initially, doing some sort of lesson will be difficult. But that's okay. The goal is to get them to see their friends they haven't seen in 5 months. So that's the main goal, and then we'll work on the educational side of it. So we're trying to take baby steps to something that it's doable. I would have a question for you both. What is what would your encouragement be to those of us, all of us probably, who are just sort of super stressed out about the constant changing of the numbers and the data and it's like, so part of me is like, okay, I believe in what I just said, and then I go and turn on Orlando Sentinel or whatever, and I'm like, okay, we need to go home and stay home. Like, how would you encourage us as God's people to sort of navigate through this in a way that's like, okay, I need to take smart risks. I don't need to freak out every time I see a new headline. But I also don't need to be cavalier about this either. I mean, have you processed out yourself, or what would you tell a patient or a parent?
I just, hear me. Yeah, I would just tell people to just really focus on the fact that we tend to, as a society, take something and run with it. So this happens to be now COVID. It's going to be flu. It's going to be something else. And so then we data drive it. I find it fascinating that we sit up there and we'll see a little ticker of how many people are dying and just panic over it, and now it's just COVID. But I would say you want to not just look at what the media is telling you, but you want to just look at what the real numbers are. And I tell my patients, don't panic. It's not as bad as it is, but use your common sense. Follow the rules to make everybody feel comfortable, even though we don't know if it's going to make that much of a difference. But for right now, we're just going to follow what we think we need to do.
I think it's tricky too, because you have this virus that can not infect somebody at all that's been exposed, and have an asymptomatic infection where they're infected and they test positive but have no symptoms, to having mild symptoms, to hospitalization to death. And there are certain risk factors that kind of lead up to that cascade. So I try to tell people, for most people, the virus is okay. It is actually not going to be harmful. If you do have those underlying medical conditions or you're older, then it's more of an issue. But young 20-year-olds who are perfectly healthy, like Owen, and these kids, I think that they will do fine with this, just like they do with any other virus. So I try to calm people down that are in the low risk groups, because it does seem that most of us, or most of society, is going to be under the age of 40 and low risk, and they need to live their lives and have fun, and the parents don't need to be so worried and anxious over their children. Like, at first we didn't know what was going to happen, but to use data, and you did an amazing job getting into the data. Like, you found more data that I couldn't find. It's so complicated, and why that is, I don't know either. But if you actually just use your brain and look at data and try not to be anxious if you're not in those risk groups. Now, if there's multi-generational families, if you're around people who are at high risk, if you are high risk yourself, then you need to mitigate to a different level than someone who is a 6-year-old child.
And so the only thing,
One other thing I want to add.
Oh yeah, go ahead.
The other thing also is, the more testing we do, the more we realize that it's not as bad as we thought it was. So we didn't know what that N number was on the bottom. And so we're doing all this testing, we're getting more and more people that we're finding have this. And so we're realizing that the death rate and the severity of it, even though it's bad, it's not as bad as we thought at the beginning, which is why we shut down this whole country. At the
It's
beginning,
the downward slope of the
they were saying we're going to have 2 million people die. They were saying 450,000 deaths were going to be in Florida. And any death is bad in regards to this, but we're only at less than 9,000. And we're seeing less and less people in the hospital. We're seeing less and less people dying in the hospital. We're seeing better care. So I tell people, people come in and they haven't gone out of the house for 3 months and they've been in the house. I say, you don't need to do that. Are you going to do that for the flu season? Are you going to do that for everything for the rest of your life? You have to start making choices that are going to be logical, safe, but also practical, so just remember that even though, and I agree, this is not going away. This is going to be part of our life. This is going to be on the list of causes of death. So you minimize it.
Yeah, picking back up on this multi-generational family, one message that I don't want to come from this session is let's just take off the mask, let's just get back to life, because most of us are going to be fine. Keep in mind that as a church, we are the best, the biggest multi-generational family. And so even if you are 20 and super duper low risk, as long as you don't have one of those 20 different comorbidities, the person next to you may be 70 and they want to come to church. And so the point of us continuing to be cautious doesn't undermine the fact that it is low risk for most of us. Is actually recognizing, but there's still many in the body of Christ for whom this is high risk for. And we want to be able to have all of us have an opportunity to worship. So two other questions from the chat.
Quick one. Are we continuing RSVPs?
Question is, are we continuing RSVPs? As long as we're in stage 2, yes, we'll continue RSVPs. As long as we feel like we need to socially distance in the worship service, we have to do RSVPs.
Second question. What are the expectations for people 75 and older and younger people with underlying conditions? Do you have any
Okay, so the question is, what are the expectations for those who are 75 and older, as well as those who are younger and maybe have underlying conditions? So would you
So
suggest?
expectations, meaning,
And I guess in terms of attendance.
I mean, the expectation on the whole is that we don't want you to come away from this thinking that there's some sort of new implied pressure that you need to be
Yes.
here.
Yeah.
Or to go to community group. It's, I made that point here. Each person needs to make your own decision based on your own factors. But we are trying to move forward comprehensively as to, okay, what does it look like to sort of get something closer to normal? Right? You want to add to that?
there's in no way, I think, are we trying to say at all that you can't come here, that if you're at a high risk, you need to stay home. We want everybody to come here if they feel comfortable. And so whether you're high risk or low risk, we just follow the principles and the guidelines that we have here to protect each other. But we also want to support everybody who wants to be here and get, even though we're social distancing, to be able to come. Just know that there is that risk. And the age risk goes, increases if you have more comorbidities, if you're older, you have a higher risk if you do get the exposure that you may have a problem. But I would not discourage anybody by any means to not come. There.
Yeah, is our high risk already welcome to come to church at this stage?
So the question is, are high-risk individuals already welcome to come during this stage? In stage 1, we had a pretty narrowly defined list of people that we would sort of encourage to come. When we moved to stage 2, we said, okay, 65 and over, as long as you're healthy, you're welcome to come. But we haven't turned anyone away. I know some people, even in stage 1, who are over 65 that came anyways, and we didn't sort of kick them out. It's a wise suggestion to say, at least know your risk factors. And be aware of them.
And the reason that was that way at the beginning is we didn't really know as much as we know now.
Right.
So we wanted to protect them more than anything else.
Right.
And now that we realize with the data what we need to do, I think it's going to be a personal choice and not the choice of the churches.
Which is what it's been the whole time.
And you do know of patients that have been elderly that have recovered.
Oh, yeah.
Fine. So if you get infected and you're older or you're high risk, there's still a great chance of recovery as well too.
Right.
We're talking 95+% recovery, if not higher. And they've all done very, very well. And the problem is we just hear about that very small percentage that just gets absolutely so over dramatized on the media that makes us all just absolutely panic about this. And that's not the case.
It's a good question. Debbie and then Walt.
My daughter is a critical care nurse practitioner in the COVID units, and she takes extra vitamin C and zinc and things like that. Could you speak to that at all? Because we found it to be very, we take it.
Yeah. In other words, should we take emergency? Would that help?
So there's been no data that actually shows that any of that really helps. There's all this just general comments, but there's no studies to validate that. It's all theoretical. You hear all this hydroxychloroquine with the zinc, with the azithromycin, and all these different combinations, and none of them have really shown to be effective. It doesn't mean you can't do it. It doesn't mean it's going to hurt you for taking these vitamins or supplements, but nothing has been shown to really be beneficial towards COVID.
I did see something in the pediatric literature, vitamin D, they were saying, but vitamin D deficiency seems to be associated with bad outcome for everything, but having good vitamin D supplementation. And then zinc and vitamin C has been studied for like regular cold viruses. I just don't think it has for this.
All right, last question, then we got to wrap up. Walt.
Yeah, somebody, my neighbor has twins going into kindergarten. She says, what should I do? And I said, well, it's your decision. I know Seminole County has like 4 plans you can choose from. And having been in the system, she's asked me because I was in the system for years. I said, I know the #1 thing for Seminole County is safety. That's the first thing. They wouldn't throw people in the water unless they're ready to swim or they had help, teachers, administrators. So their primary concern is safety for kids and their staff. And that reassured her a little bit.
Yeah. All right, well, if you have further questions, feel free to reach out to David or me. And thank you to Mike and Kim. Let's give them a hand. This session has been sponsored by Emergency. Why don't I pray for us to close? Lord, we know that you are the Lord of all things. In fact, even in our sermon series, studying your providence, that you are providentially even in control of COVID and over each one of us, and you have numbered our days. And so help us to be bold, but also in how we live in light of the shadow of death, but also deferential and respectful of others in our midst, that we might be a body of Christ that is exemplary in how we care for one another in this season. Guide our steps as we go forward in the fall, and may you just be present among us and go before us in all of our decisions. In Christ's name, amen. Thank you all for being here. Thank you all who are online.